Hey, welcome to Socialism for All. Today's date is May 10, 2022, and after a little bit of a break, I'm back with a COVID update. I haven't done one of these in a while, partly because it hasn't been entirely clear what the overall trajectory of the pandemic in the United States is. What I mean by that is it's clear that the pandemic is still ongoing. This is not over. There's absolutely no reason to think that at all. But the mainstream narrative about COVID is completely broken down to the point where it's hard to even just sort of poke holes in or fill the gaps in what has been said because not much is even being said by the government about it, by the, health officials, etc. They're kind of just ignoring the pandemic. This is an incredibly dangerous situation, and I just wonder what's going to happen the next time that there's a big spike, which may not be long. I thought that possibly the BA.2 variant of Omicron would create another big spike of COVID like it did in the UK. That hasn't happened in the United States. We're going to take a look at what may be happening as far as BA.4, BA.5, and other subvariants. Omicron has a lot of subvariants. So, anyway, I have had articles just piling up. In this COVID update, there are about 20 subtopics that I want to get to, and a lot of articles to read. So this is going to be a long update. I may do it in two parts. If so, this first part is going to be focused kind of on the sort of basic state of things and the government line about it in the United States, in the UK, in countries like Denmark, which just ended its vaccination program. It seems clear that we're moving into the sort of cover it up and don't talk about it phase of the pandemic. So we'll look at some of that and then some of the reactions against that, even somewhat within the government itself, like Biden's White House science advisor, I believe it was, announced that COVID was airborne, which is great, catching up with the research sort of that everybody else knew, but that the government for a long time didn't want to admit. But then nothing really came of that either. So anyway, like I said, the narrative seems to have broken down, and I would say that that is sort of the defining, characteristic of where we're at this stage in the pandemic, is that there's not really a big COVID narrative going anymore, other than, I mean, it's not that it's over necessarily, like they don't quite all just say it's over, but there is this sort of shrugging off and ignoring, a walking away from the pandemic. And honestly, with the way that the United States deals with things, that's pretty typical as far as just, oh, there's a big problem. Let's look at it for a certain amount of time, and then, oh, time's up. Let's just move on. Well, COVID is not something that you can just move on from, walk away from. The second part of this video, if I don't do this all in one shot, this will be coming in the second part, is going to focus on basically a long COVID update. All of the damage that COVID does, I mean, it's pretty extensive. COVID attacks your major organs like brain and nervous system, heart, lungs, liver, kidneys, major important vital organs. And it's not just during the acute phase of the infection, like the first 2 or 3 weeks. There's also long COVID, which even if you have a mild or asymptomatic bout during the first 2 or 3 weeks, you can still get long COVID. And depending on what definition of long COVID you're using, that can be anywhere from 5 to 30% of people. And if during your acute phase you had really severe COVID, that probability goes way up, closer to like 50%. Because when somebody gets hospitalized for COVID, when you read COVID hospitalization, read severe COVID injury. If your COVID is bad enough to be hospitalized for it, it has done major damage in your organs. So we're going to talk about that. One of the main ways that COVID does do damage is through inflammation. So again, if you get hospitalized, that is just ravaging your body, inflaming your major organs. It's not good. So a couple of the highlights that we have to look forward to in the second part of this COVID update, early May edition. Number one, we've got even mild COVID causes brain shrinkage and potential aging of the brain up to like 10 years worth of aging. Yeah, even mild COVID. So, there's all this, oh, Omicron's so mild, it's a natural vaccine, blah, blah, blah. Well, we don't hear that so much anymore because that was wishful thinking in the extreme. And again, kind of they're just not talking about any of this anymore. But extreme damage to vital organs, including the brain shrinkage, even from mild cases of COVID. So you might get COVID, get a cough, it feels like a cold, whatever, and you might think, well, I survived. The damage it has done to your body, just, anyway, we'll be looking at that. Point two there's been a rash of pediatric hepatitis. That's liver inflammation, in some cases even requiring liver transplants. This seems to be caused by COVID, although they're trying to blame it on other things. We will dig through the evidence on that. But anyway, let's get started. Where are we in terms of just basic stats in the pandemic? Well, here's COVID-19 wastewater monitoring, courtesy of biobot.io, biobot.io/data. We'll get you right onto this page. So as it says, this chart shows the SARS coronavirus 2 virus concentration present in samples of wastewater taken from across the U.S. The level of virus in wastewater is a leading indicator, meaning it precedes the change in clinical case counts or hospitalizations. So we've covered this many times. Basically, this is just monitoring the wastewater for viral RNA. This is a great indicator because you don't have to wait for somebody to get symptoms and then to go decide to get a test, and then for the test results to be developed and then counted and all that other stuff, which, I mean, all those steps that I just described, you're losing a lot of information because there's a lot of people who don't develop symptoms, and then a lot of people who don't decide to get a test, and then of those who do get a test, some of them are going to be falsely negative, and then even of the ones that are accurately positive, many of them won't be counted. And you also lose a week. So monitoring the wastewater, it's an excellent way to see what's actually going on. Now, that's the thick blue line here on this chart. You can see, of course, that, back in 2020, the initial spike, then there was a lull, then in the winter 2020 into 2021, huge spike. This was all before the vaccine came out. Then the vaccine came out, things quieted down for a while. Then we had Delta this past fall, basically late July into almost winter. And then in the winter, of course, in late November and December, Omicron. And that's the massive spike, which really throws off the entire scale of the graph. Then Omicron dies way down. And like I said, unlike the UK, where they had the BA.1 Omicron, which was the December-January spike, closely followed by the BA.2 spike, we didn't get a massive spike. What we have is a small spike brewing now. It's almost back up. Well, it basically is back up to the Delta levels from the fall, which was the third largest wave at that time. We're basically halfway up into the Delta spike now and well on the way. It's not really showing signs of stopping. So let's zoom in on that. Here's just the last 6 weeks, same chart, but just zoomed in on the last 6 weeks. As you can see, the lull is over. For the last 6 weeks, it has just been steadily climbing. Now, unfortunately, BioBot is a great site, but they don't always update the y-axis for some reason. You can see along the left side, 100, 200, 300. It should keep going up, and that's why that line is artificially going flat over on the right side. It's because it is going up, but the chart doesn't have anywhere for it to go. So it's just registering at 400. It was doing that a while back. That's why I can confidently say that's the reason. It's not just like, well, first of all, you can see the line nowhere just goes artificially flat except at the top. So that strongly suggests that. However, BioBot has had this issue before, then they've adjusted their charts, and I've seen the difference. So that's clearly what's happening. I wish that they would just sort of let that, auto update or something, because I would like to see where it's actually at now. It's not at 400, it's higher. So you can also see the light blue line. That's the clinical case count. And even with all the political nonsense going on, the case curve is going up. Really, I can't stress how many cases are not being counted right now. First of all, rapid tests, most of those never get counted. So a lot of people are just rapid testing, which really are very inaccurate also. I mean, it's probably better than nothing, but I've heard of people taking 3 or 4 rapid tests, which are all negative, but they had symptoms. Then they went and got a PCR test, and that was positive. So I don't really trust the rapid tests at all. That's my personal opinion. At least to say, oh, I had a negative, I'm fine. Well, yeah, I don't know about that. Anyway, continuing on, this is from the Johns Hopkins Coronavirus Resource Center. This is their page on test positivity. Test positivity is the percentage of cases that come back positive out of all the tests that are done. So, according to the World Health Organization back in 2020, basically a state or a country was supposed to show 5% or lower for at least 2 weeks before reopening. Well, as you can see, not all the states are represented here, but 28 states have higher than recommended over 5% positivity. And that's out of like 35. So as far as the other 15 states, we can probably assume that they follow a similar proportion. And yeah, so that's the overwhelming majority of US states are over 5%. Now, this is affected by how many tests are being done, and are you just testing sick people, or what's going on with like your overall testing regimen. But still, I mean, a lot of places are over 5%. So what does that mean? It means more spread. It means that a lot of people are walking around with COVID in the absence of any kind of controls, no mask mandates, no shutdowns, nothing like that. So people are just walking around with it, spreading it. And so we've got a million different strains happening. So here is a look at the CDC's Nowcast, looking at the different variants that are showing dominance. So you can see going back to, this is week by week. On the left side of the chart, you can see when BA.1, original Omicron, was dominant. That's the purple and dark purple. And then those get phased out. The pink is BA.2. That is a new variant of Omicron, or newer variant. And then even that's getting pushed out now by BA.2. And then I'm not sure how people are saying this, but BA.2.12.1. It's a bit clunky, but anyway, that's that salmon color. And that's like almost half of cases now. And my understanding is that each of these has been successively not more severe. Like all the Omicrons are roughly as severe in terms of the symptoms and the ability to cause long COVID, although there's still a lot we don't know about that. But they're all about as severe, but each one has been more and more transmissible. So they're more contagious. So you remember, like, Delta was about 5 times more severe and more contagious than original COVID. Then Omicron was several times more contagious, although slightly less severe than Delta, but still more severe than original COVID. So then the BA.2 is more contagious than the BA.1, and then the BA.2.121 even more so than that. So this is the way that it goes. And then some of the other strains, like BA.4, showing higher immune evasiveness. Before we get onto that, I just want to highlight there on the bottom the map of the 10 regions of the United States. And you can see that looks like the region with New York State in it is already 2/3 BA.2.12.1. So it's growing fast. And then right below that, over Virginia, it's over 1/3, almost half, is that new strain of BA.2, the BA.2.12.1. So anyway, moving on to Missouri. Here's a tweet from Mark Johnson at Solid Evidence. So here's the latest Missouri sewer shed data. It's a circus of Omicron sublineages. There are literally 5 strains competing against each other that each have a different residue at position 452. So just to comment on that, you'll see sometimes they'll talk about variants with mutation, and then it'll be letter, 3 numbers, and then another letter. Basically what that means is that at position, whatever the 3 numbers are, in the amino acid sequence, they went from whatever the first letter amino acid is to whatever the second letter amino acid is. So if it has, just going to make up some numbers, N452G, it means that the amino acid represented by N, which was at position 452, is now not N anymore, but the amino acid represented by the code G. So a quick guide to reading COVID mutations. So you can look at the bottom of the chart to the key. The blue is BA.1, orange is BA.2, red is Delta, that's pretty much extinct at this point. Then the yellow is the BA.2.12.1, and then the light blue is BA.2.13, And then the green, just coming in now, is BA.4 and BA.5. So, continuing the tweet, BA.1 is essentially gone, and BA.4 and 5, I can't distinguish them with my assay as coming on strong. I predicted a while ago that BA.2 12.1 would soon be the dominant lineage in the US, but it's now a horse race between the different BA.2 sublineages. So, why is all this happening? I've mentioned many times when you let, just unchecked spread, we really have to stop transmission. Vaccines are great for reducing symptoms, and you have Paxlovid that can further reduce hospitalizations, but if you just let it spread, every time a virus replicates, there is a chance of favorable mutation. There's a chance of mutation, many of which are not favorable, but some of them are going to be. And so you're just rolling the dice every time you let that virus replicate itself. So it may mutate into something that confers a significant advantage to itself, and that's how you get a new strain, which then rises and outcompetes the others, causing new symptoms potentially in the process. And when we say new symptoms, we mean new kinds of damage in the human body. That's what diseases basically do. They cause damage in your body. And it's not just the human body, because COVID does infect wildlife too, probably through sewage runoff. But anyway, we did a story back in January about how it's infecting deer populations, particularly ones that live closer to human residential areas. And then those deer are going to take it and spread it to whatever other animals they encounter that can be a host to the virus, and so on. And you may get new strains arising out of that transmission, and so on and so on. The other thing is that it's not just chance mutations. So here we have in the chart, 5 strains competing against each other simultaneously. So they're out there in the wild. Now, the question comes up, can these infect a person at the same time? Can you get more than one strain of COVID at once? Yes, you can. And then, aside from just chance mutations, COVID can engage in recombination, meaning if within a host there's more than one strain, the strains can swap genetic material, resulting in basically new recombinant strains that take pieces of the genetic material from both strains of the virus, and then it results in something new, the Omicron XE strain, which so far hasn't become dominant, but it's been detected and is being studied. This is a recombinant strain of COVID that comes from other strains, basically putting some of their pieces together. So again, these are downsides to just letting it rip. You're letting all kinds of new forms of COVID emerge. So speaking of, let's turn to an article from Forbes. This is new members of the Omicron family of viruses, BA.2.12.1, BA.4, and BA.5 by William Hazeltine. This is from April 20, 2022. I apologize for some of these articles being 2 or 3 weeks old. I literally have not been able to keep up with the flood of information coming out about COVID. And then, as far as me trying to do a video on it, trying to match this up to the dominant narrative, and, it's just, the dominant narrative has kind of been falling apart. I don't mean that in a good way, like, oh, it's, crumbling and then is having to reform itself, like, in a more truthful way. It's just sort of the discussion is ending, is closing up. And then trying to organize all this stuff is exceedingly difficult, especially with so many things happening at once. I can't stress enough, Omicron is basically a new virus almost. It is the most significantly mutated form of COVID that exists. So yes, it's similar to the original COVID or to Delta, but it is more different from those than any of the previous variants were to each other. And it's only a matter of time at this rate, with the rate that it is spitting out offshoots, these Omicron subvariants, that we're going to get something that is as different from Omicron as Omicron was from Delta and the earlier, 2021, 2020 strains of COVID, and of course 2019. All right, so let's read the article. SARS coronavirus 2 variants continue to be a topic of great concern. As weeks go by, it's evident that the Omicron family of viruses continue to grow in complexity. Figures 1 and 2 show the extent of variation from the beginning of the pandemic up to the present. So you have a graphic there, BA.2 sublineages and recombinants. The x-axis, that's left to right, is the growth rate. You can see it goes from 1, or well, 0 on the left side, up to 12. And then the confirmed number of cases per day that it causes on the y-axis. Figure 1 roughly illustrates the complexity of SARS coronavirus 2 variants, with each strain labeled by its Pango lineage designation. The vertical axis illustrates the number of people infected, and the horizontal axis displays the rate of spread of that particular variant in the population. Both axes are on a logarithmic scale. Comment, what's a logarithmic scale? If you're used to basic graphs, these are linear, like, for each tick, it's like 1, 2, 3, 4, 5, etc. Logarithmic is not linear, it's closer to exponential. So basically, if you see a linear curve, like just a line going up, on a logarithmic chart, that is exponential growth. So more like multiples of 10. Anyway, the relative growth rate is described as how many additional people are infected by one infected person. For instance, BA.2 exceeding 12. Reading the figure from left to right, the original set of variants before Delta in late 2020 and early 2021 is shown as a cloud of variants, distinguished by unique mutations around the common blueprint D614G triad variant. Figure 2 illustrates the emergence of new variants by date and relative growth rate. We'll just show that quickly here. It's actually several paragraphs down. There it is. We'll come back to it. As we move from left to right across, we note that the rate of spread in populations increases. Notably, this occurs in many populations that have been either heavily infected, highly vaccinated, or both. The second cloud of variants comes from the Delta variant. These variants were more pathogenic and spread through the population more rapidly than the previous isolates. Then there is a gap as the emergence of new variants slowed. Over the past few months, the Delta cloud was displaced by two distinct families. The earlier was the BA.1 family of variants, followed by the current BA.2 family. Within the BA.2 family, many different variants have been identified, including some that fuel more infections than others. For example, the BA.2.12.1 variant spreading widely in the Northeast United States. So look at that chart again. This is the BA.2 sublineages and recombinants, or figure 2, the relative growth rate of SARS coronavirus 2 variants compared to their date of lineage emergence, so when they showed up. So you can see there, the relative growth rate, that's the higher you go on the Y, the up and down axis, and then the date of emergence is earlier on the left and then later on the right. So where are we now, present day, later on the right? Well, we got strains that have the highest relative growth rate, and not by a little bit, by a lot. So make no mistake, this is the consequence. Omicron is the consequence of not stopping transmission. Now, they mentioned that this is also present in more highly vaccinated populations. There's nothing wrong with the vaccine in itself, but if you do not pair it with stopping transmission, then you do set yourself up for a situation like this potentially, because the vaccine is, a roadblock, an obstacle to the virus. The virus is, of course, a more fit virus will adapt to the vaccine. Let's put it that way. And so the vaccine is great for stopping some of the most serious symptoms, but it does not mean you can go about business as normal, which is exactly what all of the capitalist governments have been saying. It's like, oh, mask or vax. No. Vax and keep masking, because the vaccine is great if you do happen, if you're careful, if you mask, if there are shutdowns, and you still catch it anyway. But you're not supposed to just get it and say, oh, well, I'm vaccinated, so it's fine. First of all, there are breakthrough cases, so you may not be fine, even if you are vaccinated. I mean, get vaccinated, get your booster, etc. It definitely, if you're careful and everything, and you still catch it anyway, it's going to reduce your odds of having really severe, acute symptoms. You don't want severe acute symptoms, so get vaccinated. That said, we also have to stop transmission, which has just not really been a priority in the United States or in similar imperialist countries. So highly mutated forms of COVID is the result of that. Anyway, continuing. Outside of the United States, two new variants are gaining attention from the World Health Organization as they grow in their sequence and infection count. BA.4 and BA.5, which are offshoots of the BA.2 family. And just to note there, BA.2 and BA.1, it's not like BA.1 came first and then gave rise to BA.2. They are more like siblings. They co-evolved separately from a parent. So it's not like, oh, if you have BA.1, then you can probably deal with BA.2. You can get reinfected. I mean, you can get reinfected by even the same strain of Omicron, but you can get reinfected that much more easily by different strains of Omicron, just to be clear. But BA.4 and 5 come from BA.2 specifically. Continuing. As the thumbnail of this article makes clear, BA.4 and BA.5 are growing rapidly to dominate the South African population. Comment, we're going to have an update on that and how that turned out. Spoiler alert, not good. We note that just because instances of BA.4 and BA.5 are increasing as a relative proportion, that doesn't mean that the total number of cases is increasing in South Africa. Case rates are low and stable at the time of this writing. Again, spoiler alert, that did not hold. The Omicron subvariants BA.4 and BA.5 share most mutations with the original BA.2 Omicron variant, but each has its distinct mutations from BA.2 and one another. Here, we examine these two subvariants and the new modifications they possess. For reference, the BA.2 spike protein contains 28 amino acid mutations compared to the original Wuhan strain. 15 of these are concentrated in the receptor binding domain. Comment, what is the receptor binding domain? This is the part of the virus that binds to the host cell. Continuing. In addition to the mutations in the receptor binding domain, there are also a number of mutations in the N-terminal domain and the membrane associated S2 region in the spike. So there's a lot of technical stuff in the next few sections, which I think is not incredibly important, but I do want to summarize some of the findings. So talking about 4 particular mutations, they're talking about the Q493R mutation in BA.2. There are studies indicating that Q493R is an escape mutation for some monoclonal antibody treatments. This suggests that BA.4 and BA.5 actually may be more susceptible to treatment by monoclonal antibodies, but there needs to be further study. Another mutation is the L452R mutation. This is common in existing variants. It induces a change in charge from positive to neutral, and it's cited for contributing to immune escape from antibody binding. It may also contribute to stronger cell attachment to the virus. So basically this results in increased transmissibility or contagiousness and increased pathogenicity or ability to cause disease because it can escape your immune system, and it also may bind more strongly to the cells in your body. So not good all around. Then the next mutation is F486V. This doesn't induce a polar or a charge shift, but according to Dr. Jesse Bloom, it could, quote, lead to more antibody escape from serum elicited by current vaccines and early infections, unquote, but further research is needed. And then finally, there is a deletion of positions 69 and 70 in the N-terminal domain. So it's a pretty technical article for Forbes, but the N-terminus is a position within a chain of peptides. Anyway, it's a common mutation found in natural variants, and it likely knocks out an antibody binding site. So antibodies are, of course, what take out these antigens. So if you take out the antibody binding site, that could help the virus to escape your immune system. So continuing the article, the rate at which the virus spreads through a population that has a large percentage of COVID-19 recoveries is determined both by the number of people who have been previously infected as well as the number of those vaccinated. A new variant must have the viral fitness to overcome immune defenses developed during previous infections and vaccinations in order to spread in such a population. One way of understanding escape from a waning immunity is to look at the sensitivity of variants to monoclonal antibodies based on certain escape mutations. Despite the mutation at position 493 reverting to its original state, the inclusion of the N-terminal domain deletion, F486V, and L452R, may yield a more immune-evasive virus overall. Both receptor binding domain mutations were cited by Dr. Tulio de Oliveira as being associated with escape neutralization from all classes of monoclonal antibodies. So just a comment there, monoclonal antibodies are one of the main treatments that they give to people in the hospital. Basically, antibodies, again, these are things that pick up antigens or, foreign things in your body and neutralize them. They help, remove their ability to cause disease in your body. So, I mean, we already have the problem of the US government at the most recent round of COVID funding refused to pass the full measure. And so we already have a limited supply of monoclonal antibodies in the first place. And now we're also having variants that are possibly becoming more capable of evading them. So the article goes on, it gets even more technical about some of the mutations. I'm going to skip over that because I feel like I'm probably losing people going through all of that, but I'll go to the conclusion. So he says that these viruses should not be underestimated. For every person infected with the Wuhan strain, these viruses may infect roughly 12. So you could say it's 12 times more contagious. That's leads to some pretty big numbers pretty quickly. Previous mitigation methods have spared China the level of infections rampant elsewhere. However, mild increases in cases in comparison seem to show it is more difficult to contain the spread of the Omicron variants. So, commenting, that is true. China has been pursuing a zero COVID policy, which makes a lot of sense, because if you don't pursue a zero COVID policy and just tolerate it, as the United States and many other capitalist countries have been doing, it gets out of hand really fast. It mutates, it spreads. China has been really effective so far at preventing cases and deaths because, as we're going to look at in part two, even mild cases can result in severe damage to a person's organ system. And then, I mean, we're only like beginning the third year here. The kind of health impacts we're going to see at years 5, 6, 10, who the hell knows, But they're really trying to avoid cases and spread it all because you just don't know where it's going to go if you do. But they do really seem to be having trouble with Omicron. Again, it's like Omicron is the most mutated by far. It's almost like dealing with a different disease. So even China is having difficulty. Continuing, based on observations thus far, I doubt that SARS coronavirus 2 has reached the upper limits of its rate of spread in either vaccinated or unvaccinated populations. I think new variants may emerge with substantially increased virulence. That's severity of disease. We should remember that a closely related virus to SARS coronavirus 2, MERS coronavirus, kills roughly 50% of those it infects. And commenting, we're going to be covering a study about a coronavirus that was allowed to spread 15 generations in mice, at which point it became really lethal. So, yet another reason to not just let the thing rip. Continuing, the story of the Omicron family of variants is still emerging and one that the world is watching closely. It is unfortunate that at a time when surveillance of infection rates and strain identification is crucial, those efforts are declining rapidly worldwide. This strikes as a grave mistake, as surveillance is the best early warning signal for new and perhaps more dangerous variants. So that's the end of that article. And this note about not doing the surveillance and monitoring work, turning your back on COVID, as the US clearly seems to be attempting to do, is suicide. It's a deadly, deadly move that, it's really just ostrich like head in the sand. It's not going to help you at all. You're still vulnerable, you're still exposed. And here is Dr. Tedros Ghebreyesus of the World Health Organization talking about that.
The South African scientists who identified Omicron late last year have now reported two more Omicron subvariants, BA.4 and BA.5, as the reason for a spike in cases in South Africa. It's too soon to know whether these new subvariants can cause more severe disease than other Omicron subvariants, but early data suggests vaccination remains protective against severe disease and death. Testing and sequencing remain absolutely critical. The BA.4 and BA.5 subvariants were identified because South Africa is still doing the vital genetic sequencing that many other countries have stopped doing. In many countries, we're essentially blind to how the virus is mutating. We don't know what's coming next.
All right, so on that note of the spike of cases that is happening in South Africa, here's a chart. Estimated SARS coronavirus 2 infections per day by variant in South Africa. So you can see the different waves. So there's the initial variant, then the beta wave, then the alpha is sort of mixed in there with the delta, then the huge spike, Omicron, that was, December or like November into December, January. And then the original Omicron hangs around for quite a while. It actually has sort of a second bump, but something else comes in. That's the darker red. That is the BA.2 Omicron. Now, the second Omicron didn't give the same kind of spike that the first Omicron did. It did in some countries, but not in South Africa. In fact, it didn't even get quite up to the Delta level. Not that, I mean, Delta level was pretty bad. Not that not reaching that mark means it's fine, because again, Delta was pretty bad. But BA.2 there in South Africa didn't turn into this massive like second Omicron spike. It was more of like a after dinner snack. Then look at the yellow and tan, those sort of like beige tan colors. That's your new spike, which is second only to the Omicron BA.1 wave from December and January. Now, I should mention that the label of this graph is estimated infections. So this is it's down in the right corner, T. Wenslers on Twitter from April 25. So we're about 2 weeks past this. He described a particular process that he used. So the confirmed cases are lower at this point, although it's really just continued to climb since, in the last 2 weeks, basically. The confirmed cases continue to go up. They are lower. I think it's about 10,000 cases a day currently. But anecdotally, I read that basically, unless you're on death's door, it's nearly impossible to get a test in South Africa. So confirmed cases are going to be lower. That's why the estimated cases are much higher, and that's what I led with. In either case, there's a big spike, and it's not done yet, and BA.4 and BA.5 are more contagious than the earlier strains. This is something to be concerned about. But are the Western governments concerned about it? No. The next cluster of things we're going to look at is basically how the US is responding, also countries like Denmark and the UK, and then some responses. People have started what they're calling the People's CDC. We're going to take a look at some public opinion polls on masking, as well as some other things, so let's get into that. Here's a PBS NewsHour article. The title is Dr. Fauci on why the US is, quote, out of the pandemic phase. This is from April 26th this year. I absolutely cannot believe that he would say something like this, but let's get into it. As COVID cases begin to pick up across the U.S., the Centers for Disease Control and Prevention, really misnamed agency in my opinion at this point, on Tuesday said that 3 out of every 4 children have been infected by COVID. So commenting on that, when we get into the brain shrinkage stuff, remember that. This comes as the White House moved to make Paxlovid pills, which can reduce serious illness, more widely available. Dr. Anthony Fauci, President Biden's chief medical advisor, joins Judy Woodruff to discuss. Here's the transcript. Woodruff says, let's look now at the latest news on COVID and what is needed now. I spoke earlier today with President Biden's chief medical advisor, Dr. Fauci, as part of the upcoming Crosscut Festival for KCTS 9. That is the PBS station in Seattle. Our full discussion can be seen during the festival, which runs May 3rd to the 7th. Dr. Fauci, thank you very much for joining us. So much to talk about. But I want to start with new data that we are learning about how many Americans have been infected with the COVID virus. Among all U.S. Americans, and I think this dates back to February, 60% almost had been infected. And among children, 75% had been infected. First of all, were you surprised by these numbers? And second of all, does this in your mind change the way there should be an official response to the virus? Comment. Anyone with any sense at this point would stand up and say, yes, this is completely unacceptable. We need to change course. Here's what Anthony Fauci said, chief medical advisor to President Biden. Well, I wasn't terribly surprised, Judy, because we have been having this virus around now for almost 2.5 years. Comment. And we've been doing fuck all about it. So the idea that if you look at the serology, which is the antibody test in the blood, which determines whether you've been infected or not, it's not surprising that you have that proportion of the population. Comment. And we don't really fucking give a shit, clearly. I think it's important for people to realize that because although immunity following infection and recovery does not last indefinitely, it does give a variable degrees of protection against severe disease if you get reinfected. I can't believe he's saying this. I really can't. Because we know it wanes in a matter of months, like literally by month 4 or 5. you're down to like a small fraction of the protection. This is just, he's lying. I mean, there's no other real way to say it. This is misinformation. So if you add up the people who've been infected plus the people who've been vaccinated and hopefully boosted, you have a rather substantial proportion of the U.S. population that has some degree of immunity that's residual, either residual from prior infection or hopefully people who are getting vaccinated and boosted. We know we have 66% of the total population has been vaccinated, and about half of them, so 33%, have been boosted. Woodruff. In connection with all this, Dr. Fauci, we live in the northeast of the United States. We're hearing about more cases here, including prominent members of the public, including lawmakers, the Vice President of the United States. Many of them are having mild or no symptoms at all. What does that tell us about how many more Americans who aren't getting tested as regularly as these individuals are, who may just be walking around with COVID but not aware of it? Yeah, so again, this is the point where anyone with any sense says, yes, it's unacceptable, it's contributing to the rise of new variants. We really need to stop transmission and stop just focusing on acute symptoms, because whether it's the emergence of new variants or whether it's long COVID, the acute phase of the infection doesn't necessarily tell us that much. But here's what Fauci said. I think you just hit the nail on the head there, Judy, because I'm virtually certain that we are undercounting the number of infections for the same reason. There are many people who I know myself, friends and others, who get infected, who do an antigen test, don't get many symptoms, but don't report it to anyone. So the fact is there are infections that are not getting centrally reported. So I do believe that there's an undercount. We should do better than that. We should probably be able to track them better. Yeah, probably. I mean, yeah, if you can swing it, you can manage it. But the good news is the one you mentioned, and you're absolutely correct. The relationship or ratio between hospitalizations and infections is such that we're not seeing a comparable increase proportionately of hospitalizations, unlike what was happening with Delta when, as the cases went way up, the hospitalizations also went way up. Comment. So that's currently with this variant, but the variant that emerges tomorrow or the next day might turn that on its head. Also, it's one thing to say, well, step one is we got the hospitalizations and deaths down, but also long COVID is a real problem, et cetera, et cetera. He's not saying any of that. It's really this kind of like out of sight, out of mind thing. Like if it's not absolutely exploding and on flames, it's okay. You really need to move the bar to a more sensitive threshold there, which is actually the exact opposite of what the CDC has been doing. The CDC, as I've covered in some earlier live streams, they rolled out, their new like community risk profile, which is just, basically they will consider an area, in the green go good zone if there are a lot of open hospital beds. No. So like you don't do this in any other area of public health. Like, oh, there's open hospital beds. Everybody drink and drive now. Don't wear your bike helmet because there's open hospital beds. That's not like a serious response to this. That is a sweep it under the rug response. Woodruff continues, should we have stricter reporting requirements, though, so that the country can just keep better track of how many cases there are? Careful, Judy. Accurate count, that might freak people out. Fauci, yes, I would like to see that. Of course, he's probably just saying that knowing that it's not going to happen. I would like to see a way where when you get an antigen test, somehow or other, you can put it in an app and just get some way of recording it. It would give us a much better feel and a much better understanding of the scope of any rebound. Even though it's a mild rebound, you really like to know what the accurate counting of cases is. Woodruff. Well, for those who are having symptoms now, Dr. Fauci, there's been a fair amount of discussion lately about a treatment, a drug called Paxlovid. And I know there are generic names for it as well, a fair amount of confusion about who should be taking it and who shouldn't. There's a sense that it's not available to many people who need it. It does require a doctor's prescription. We're told that it's available, but it's not reaching everyone who needs it. What should we know about this drug? Fauci. We are underutilizing what is a highly effective therapy. In clinical trials, when you look at the proportion of individuals who are protected from getting on and progressing to hospitalizations, it was close to 90%. So we need to do more. There are a lot of doses available. We have sites where you can, as we say, test to treat, which means you can come into a place, get tested, and if you're tested, immediately get put on therapy if they're eligible. We've ordered tens of thousands more of these drugs, namely Paxlovid, and we're having sites where there are now, we've started off with 20,000 sites. have Paxlovid available. We're increasing that to 30,000 with the aim of going to 40,000, essentially doubling the number of sites where you can get it. And I mean pharmacies and clinics and places like that, as well as something that's important you alluded to is educating the public and the healthcare providers that this is something that is available and that should be much more widely used. Now, let me just comment there. So Paxlovid is good for keeping people out of the hospital. Again, this seems to be the U.S.'s priority, not at stopping the spread, not at stopping long COVID, but just sort of like not having the hospitals get overloaded and, you know, have people succumb during that initial acute phase during the first 2 or 3 weeks. And okay, that's good. I mean, there's a lot of people who have died during that acute phase. But I mean, two things. You're basically building up an epidemic of disabilities through long COVID. That's going to have catastrophic effects. I mean, at some point, like it's just adding up and adding up. I personally believe I had long COVID for about a year. I really only noticed when it started lifting after a year. And yeah, I mean, let's put it this way. I noticed when I had it, but I really noticed when I went back to feeling better again, like how big the difference was. And I didn't really have a bad acute phase. I had a lot of fatigue and I felt uncomfortable, you know, like kind of hot and cold at the same time, that sort of thing. But, you know, I didn't really have massive breathing problems or cough or stuff like that. But then I felt like I was affected. I had shortness of breath and fatigue and brain fog for like a year, significantly, noticeably. You know, like I said, especially when it lifted, because I was like, oh, wow, I can like breathe and think again. Interesting. You know, you almost forget after a while. But anyway, about Paxlovid, that's good. The only caveat with Paxlovid, we're going to do a story on this later, is that there does seem to be this sort of bounce back effect. They have noticed it in the clinical trials and then also in practice, where people, basically the course of the drug is 5 days, and people will take it and then test negative, but then about 10% of the people or something like that, again, we'll read the article, actually test positive again on like day 8 or 9, something like that. So it's not quite a catch-all. It is very good at what it does, though, but we will take a look at that article, too. All right, back to the interview. Woodruff says, Dr. Fauci, let me broaden this out and ask you. Here we are. It's the end of April. It's the spring of 2022. How close are we to the end of this pandemic? Fauci, well, that's an unanswerable question for the following reason, and I don't want to be evasive about it, but let me tell you why I'm giving you that answer, Judy. We're certainly right now in this country out of the pandemic phase. Holy shit. I want to say, what does that even mean? He's about to say, that is, I think, one of the most irresponsible statements you could possibly make. But anyway, namely, we don't have 900,000 new infections a day. Yeah, guess what? The pandemic's been going for over 2 years, like basically 2.5 years if we're going from December 2019. And there's only been really one point where we've had 900,000 new infections a day, and that was very recently. So if that's your bar, then we weren't in a pandemic until fucking Omicron. Astounding. It's just the way that they moved the goalposts on this. Also, Omicron was like a few months ago. I don't know. Anyway, namely, we don't have 900,000 new infections a day and tens of thousands of hospitalizations and thousands of deaths. We're at a low level right now. Comment. That doesn't mean we're out of the pandemic. It means we're not in the middle of a surge. This is amazing, the way he's abusing the terminology. So, if you're saying we're out of the pandemic phase in this country, we are. No, we're fucking not. We're just between surges, you absolute fucking asshat. Unbelievable. What we hope to do, I don't believe, and I've spoken about this widely, we're not going to eradicate this virus. Okay, maybe because you haven't set that as a goal. Just a thought. If we can keep that level very low and intermittently vaccinate people, and I don't know how often that would have to be, Judy, that might be every year. It might be long. No, how would it be every year? We know that the vaccine wanes significantly and natural immunity wanes after about, 5-6 months. You're back to like being really vulnerable. That's why there's a surge that often. Okay? Anyway, unless you really develop a new, different type of vaccine. But anyway, that might be every year, it might be longer in order to keep that level low. This is delusional wishful thinking. So why haven't we been able to do that so far? Huh? Like, we've had the vaccine now for a year, and we've had Delta, we've had Omicron, and we have another wave brewing now. So why haven't we been able to do that? So this is just a lie. But right now, we're not in the pandemic phase in this country. Pandemic means a widespread, throughout the world infection that spreads rapidly among people. That's exactly what it's doing. That's exactly what it is doing. So he has sidestepped saying that it's endemic. But endemic and huge spikes do not go together. But that's basically what he's implying. No, we just had the worst surge by far just a few months ago. We're not out of the woods. You have absolutely no basis for saying that. If, when would we be out of the pandemic phase? So you look at how often the average surge comes. And then let's say that, it's been about every 5 or 6 months. Let's say you go 9 months and you don't really have a surge. You might at that point start speculating, is it over? But it would still be irresponsible to declare it over. When you hit 13, 14 months, like by the time that you should have had 2 surges and you haven't had a surge, maybe then you can start saying, I think that it might be over. We literally just had the biggest surge by far a few months ago. Anyway, and then he bizarrely concludes with, so if you look at the global situation, there's no doubt this pandemic is still ongoing. What? What's the difference? And how do you think that that's not going to just come back to the US, even like if we're accepting your premise that we're not in the pandemic? Just amazing. Just amazing. So anyway, I mean, people have just been recently vaccinated. Some people, myself included, we're still wearing masks and things. I mean, and people are being cautious. There is a great degree of spread, and it's building by the day currently. What are you talking about? I mean, yes, people are still riding off the booster shots and the natural immunity that if they survived Omicron, that they're carrying from Omicron. But that does not make the end of a pandemic. This guy is lying. So anyway, Woodruff thanks him, and that's the end of that. So that's the U.S. Moving over to Denmark, we have another story from April 29. Denmark becomes the first country to stop its vaccination program against COVID-19. What could go wrong? The decision is made with 89% of the adult population with the complete vaccination schedule. This is from the entrepreneur.com staff. The unthinkable just a few months ago has happened. A country has stopped its vaccination program against COVID-19 due to the low rate of infections in recent weeks. Again, we're at the tail end of a large surge. People are riding off the natural immunity. This is not permanent. Anyway, like, is it me? I feel like I'm going crazy here, but anyway. This is Denmark, and with the decision, it becomes the first country in the world to pause its vaccination plan. Through a statement, the National Board of Health explained, quote, spring has arrived, vaccination coverage in the Danish population is high, and the epidemic has been reversed. Therefore, the National Board of Health is now finalizing extensive vaccination efforts against COVID-19 for this season. This means, among other things, that invitations for vaccinations will no longer be sent. According to the official data, 89% of the population over 12 years of age already have the complete vaccination schedule, and 76% of adults have already received the booster injection. According to the Worldometer site, the number of infections in the Scandinavian country has decreased in recent days. In fact, on April 25, only 910 cases were registered. Think about that, though. That's still 910 cases in a day. Knowing what we know about COVID, is there potential for that to rebound? Yes, absolutely. After a maximum of 52,000 infections in a single day was reached on February 2. Okay, that's a big difference. It's, about 60-fold, but that's because a surge has concluded and people have temporary immunity. The number of deaths has also decreased considerably. During the last week, the maximum per day was 21, although the average was 10. As the Danish Health Division declared to Fortune magazine, the situation is, quote, favorable. Quote, we will continue to closely monitor the development of the epidemic, and we're ready to resume the general vaccination program if the need arises before a new outbreak begins. COVID-19 season in the fall, he added. Although invitations will no longer be sent from May 15, there will still be vaccines in health centers for those who wish to apply them. People at risk may receive a fourth booster dose. So who's at risk? They don't say. As we get into part 2 of this video, the long COVID stuff, I mean, a lot of people are at risk. But anyway, it is believed that despite the relaxation in vaccination, it will be resumed when autumn arrives and another possible peak of infections for the season. And, let's hope that, unlike South Africa, you don't get another massive surge before that, which is possible. I don't know, what they'll do then, or what the point of this even is. It's like, is this to just appease the contrarians? Just they're tired of the vaccines being a contentious issue? They're still going to be available to people, but anyway, it just seems like a bizarre move. So, getting into the ideological question, here's an article from The Guardian by Kevin Rawlinson, dated April 11. Headline is, COVID threat being ignored in England for ideological reasons, say NHS leaders. NHS Confederation calls for living with COVID plans to be reconsidered as the health system struggles. So I'll say this about England, for all their deficits, they are taking long COVID pretty seriously. I mean, as far as the sort of long COVID awareness raising, there's a lot of that going on in the UK. So ministers should reconsider England's, quote, living with COVID plans, health leaders have said, while accusing the government of ignoring the ongoing threat for ideological reasons. The NHS Confederation, which represents organizations across the healthcare sector, has accused Number 10 of having, quote, abandoned any interest in the pandemic, despite a new Omicron surge putting pressure on an already overstretched NHS. They are talking, of course, about BA.2. Quote, the brutal reality for staff and patients is that this Easter in the NHS is as bad as any winter, said Matthew Taylor, the chief executive of the NHS Confederation. Quote, but instead of the understanding and support NHS staff received during 2020 and 2021, we have a government that seems to want to wash its hands of responsibility for what's occurring in plain sight in local services up and down the country. Number 10, that's like their White House, has seemingly abandoned any interest in COVID whatsoever. NHS leaders and their teams feel abandoned by the government, and they deserve better. Unquote. Taylor later told BBC Breakfast, quote, in our view, we do not have a living with COVID plan. We have a living without restrictions ideology, which is different. We need to put in place the measures that are necessary to try to alleviate the pressures on our health service while this virus continues to affect it, unquote. He said ministers should restate advice promoting mask wearing on public transport to try to cut the number of infections and consequently the demand on the NHS. Quote, we need to renew the call for people to have vaccinations and booster vaccinations. There are still a lot of people out there who are not up to date with the vaccinations that they could have, he said. Quote, we need to resource the health service. At the moment, for example, the health service is providing free tests for its staff, which it needs to do because staff absences are really high in the NHS because of COVID. But the NHS has to pay for those tests. So we need to put the resource in, because we're behaving as if this pandemic is over, but it is not over in relation to the challenges facing the health service, unquote. A new Omicron wave has been putting immense pressure on the NHS. Last week, health bosses in England issued an extraordinary plea for families to help them discharge loved ones, even if they were COVID positive, saying that the service faced a, quote, perfect storm, fueled by heavy demand, severe staff shortages, and soaring cases. Quote, our concern is that there's a lack of awareness and engagement with the pressures the health service is under, and it's particularly felt in hospitals and in the ambulance service, but it's actually across the system as a whole, Taylor said. Quote, although of course we're much better at dealing with COVID than we've been in the past, fewer people die, fewer people end up in intensive care, it's still a disease that puts immense pressure on the health service. It is adding to the demand which already exists, partly to do with the number of people who are waiting for treatment, which built up during COVID. Comment. So, when all the acute care, emergency care was needed for COVID, all of the, organ transplants and like all that other stuff got like backlogged. So anyway, quote, so we have a situation in our health service now which is as bad as any winter, even though we're approaching Easter. Taylor said that to make matters worse, the Treasury had, quote, taken bites out of the already very tight NHS budget, while soaring inflation meant the NHS settlement was now worthless. Quote, it is now unclear that anyone in the center of government feels the unfolding NHS crisis is their responsibility, the FT quoted him as saying. A number 10 spokesperson said, quote, there's no change to our guidance and our living with COVID plan still stands. I mean, sure, ignore what's being said. Thanks to a combination of vaccination and treatment and our better understanding of the virus, we're now able to manage it as we do with other respiratory infections. No, COVID is not, first of all, it's not just a respiratory infection in the first place. Yes, the primary target that it hits is the lungs and respiratory tract. However, it also, close behind, affects the liver, heart, kidneys, brain and nervous system. I mentioned the heart, but the rest of the cardiovascular system as well, the male reproductive system, like the list goes on. So just calling it another respiratory infection is not science, it's misleading, it's COVID misinformation. Continuing, so that remains the case with our approach, but obviously we continue to monitor any changes in the behavior of the virus, unquote. That's a terrible policy. Asked about the Confederation's view that NHS leaders felt abandoned by the government, the spokesperson said, quote, we're incredibly grateful to NHS staff who worked flat out through the pandemic and continue to do so in the face of COVID backlogs, unquote. Okay, so in other words, pat on the head, thoughts and prayers. But that kind of empty praise, doesn't obviously really address the question at hand. And some people have decided to start taking steps to get organized to combat this. So here's another Guardian article. This is from April 3rd. The headline is, the CDC is beholden to corporations and has lost our trust. We need to start our own people's CDC. We're epidemiologists, nurses and physicians, artists and biologists. We've come together with a common anger at the U.S. government's handling of COVID. So this is back to the U.S. now. A new Omicron variant, referred to as BA.2, is taking hold in the U.S. Anthony Fauci and others have said that they don't expect a new surge in the U.S., but BA.2 is causing devastating surges elsewhere, and the policies and behaviors we might use to prevent a surge in the U.S. have been widely abandoned, in part thanks to the CDC's new system for measuring and conveying COVID risk. In late February, the U.S. Centers for Disease Control and Prevention, CDC, unveiled a new COVID-19 monitoring system based on what they call community levels. By downplaying the importance of SARS coronavirus 2 transmission, the new system instantly turned what was a pandemic map, still red from Omicron transmission, to green, creating the false impression that the pandemic is over. And commenting, again, this really seems like the illusion they are trying very hard to sell. Released 4 days before the State of the Union, the new CDC measures and the narrative they created let President Biden claim victory over the virus via sleight of hand. Comment, this is what he tried to do last summer, too. Actually, this time of year, again, it's spring, go spend money, mission accomplished, and then Delta started up in July. So, yeah, a switch from standard reporting of community transmissions to measures of risk based largely on contentious hospital-based metrics. The previous guidelines called anything over 50 cases per 100,000 people substantial or high. Now, they say that 200 cases, 4 times more, per 100,000 is, quote, low, as long as hospitalizations are also low. Comment, this is let it rip on steroids. It's like they don't really care how much it's spreading, how much it's mutating, etc. As long as the hospitals aren't completely overflowing, they're literally giving it the green light. The resulting shift from a red map to a green one reflected no real reduction in transmission risk. It was a resort to rhetoric, an effort to craft a success story that would explain away hundreds of thousands of preventable deaths and the continued threat the virus poses. These new guidelines are at odds with evidence-based and equitable public health practice in 3 fundamental ways. First, they do not intend to prevent disease spread by minimizing the importance of new cases and focusing instead on hospitalizations, a lagging indicator. I would add lagging by at least 2 or 3 weeks. The revamped warning system delays action until surges are well underway, and the consequences of severe disease and death are already in motion. Making matters worse, at-home tests are not recorded in the U.S., so the only early indicator in the risk level calculation grossly undercounts the true number of cases. So comment, we started out this video talking about sewage monitoring, wastewater. It's already being done. It's not terribly difficult. Why isn't this being included? Because that is one of the earliest ways to catch it. So it's not. Anyway, the justification for the shift is that the virus is mostly harmless, a claim which not only ignores that 1 million people have already died in the U.S. alone, but also completely erases the reality of long COVID. Studies indicate that 10 to 30% of COVID infections deteriorate into multiple debilitating syndromes lasting months to years. Minimizing COVID's risks to the public will only increase these harms in our communities. Secondly, the new guidelines do more than inappropriately message safety. The guidelines shift the burden of responsibility onto vulnerable people. In place of clear, evidence-based guidance on masking for those facing greater risk, for example, the CDC simply advises individuals to consult with their local healthcare provider. Comment, and what do we know about that? Many doctors' offices haven't even been requiring their staff to wear masks, if it's more of like a, reactionary right-wing practice. So your doctor might just be like, COVID isn't real, there's still those types around. So that's horribly irresponsible from a public health standpoint. Anyway, it's just assigning things that need to be much more structural to like more of a micro, or close to it level. This instruction assumes that providers are accessible, well-informed, also that people have providers, and willing to take on the personal liability for giving guidance around a potentially fatal virus that the CDC was once responsible for. In a country without healthcare for all, these assumptions are wrong. Even before these changes, Biden and the CDC declared the U.S. faced a, quote, pandemic of the unvaccinated, disregarding the risks faced by those of us living with chronic diseases and disabilities, including the immunocompromised, those with lower incomes and higher risk jobs, members of indigenous, Black, and Latinx communities, the elderly, the pregnant, and children, especially under 5 years old. These vulnerable populations have unjustly had too little access to vaccines, masks, testing, and clean air. Many faced employment practices forcing them into unsafe, in-person work, while those more privileged protected themselves by working and learning remotely. We've already seen the consequences of these inequities: disproportionate death and disability in structurally vulnerable communities. Now, by increasing transmissions, inequities will continue to multiply as the pandemic continues. Thirdly, the guidelines are blatantly political. The new recommendations aim to convince the public that this pandemic is over when it is not. They suggest that we tolerate the nearly 1 million U.S. dead and to quickly abandon measures that would keep that number from growing. They suggest we continue to isolate those with chronic illness and disability while the rest return to, quote, normal life. They suggest that long COVID isn't the rapidly growing crisis that it is, especially for the fully vaccinated, despite documented risks of ongoing and sometimes disabling symptoms. They dismiss the near inevitable emergence of new variants. They dismiss the urgency to vaccinate the rest of the world. Before the new CDC guidelines, the vulnerable were moderately protected by local mask mandates, passing shelter-in-place recommendations, and general support for public health interventions aimed at collective well-being. There was at least some urgency around vaccination campaigns and occupational protections against the virus. There was recognition that COVID was still a threat. Changing the metrics alone permitted jurisdictions across the U.S. to retire mask mandates and people to retire their masks. As successful health campaigns are interrelated, efforts to vaccinate against COVID and improve ventilation in schools and work have also lost steam. Yeah, commenting the entire thing about, making large institutions responsible for upgrading ventilation and stuff. Well, hey, we're out of the pandemic phase, according to Fauci. So, how do you think legal challenges for a large company or other large institution to spend hundreds of thousands of dollars changing its ventilation system, how do you think that would hold up when you've got, Biden's like leading health advisor declaring that we're out of the pandemic phase. The shift from red to green reflects both major U.S. parties turning the page on the virus as a political problem rather than a change in the reality of the pandemic. The red to green shift also paved the way for the political class to wash their hands of would-be fights over COVID funding. Some claim that the White House and the CDC are, quote, following the science and doing the best that they can in these times. Comment there. Biden's White House has never done that. His COVID czar is a guy named Jeff Zients. Look it up, Zients. I did a video on this channel about it. He is from Bain Capital, same place Mitt Romney came from. No public health experience, but yet he is the lead COVID response person in Biden's White House. So what does that tell you about the priorities? But if the goal is to prevent infection and suffering, not to mention more mutations, the updated recommendations do not align with science or equity. It's more accurate to say that they're following the money. They've put the desires of corporate America above the needs of our people, and especially our most vulnerable. We need a CDC that prioritizes the health of the people, not the health of big business. We need a people's CDC, and so we formed one. We're epidemiologists and physicians, artists and biologists. We're children, parents, and grandparents. We're living with long COVID and losses of loved ones. We've come together with a common anger at our government's disregard for social and public health responsibilities. Though many of us have just met, we inherit hundreds of years of resistance traditions. We greet this work with humility, recognizing that there are still many uncertainties about new variants, long COVID, and the future of therapeutics. Yet we know enough to reject with certainty ineffectual public health policies based on individualistic approaches. And we are certain that there is another way, that collective action has always and can now create a new way forward in responding to COVID and other deadly pathogens. We've already put out a statement and recommendations about BA.2, a statement regarding the CDC's new recommendations, and we brought together a coalition of groups to create an equity-focused toolkit to help parents and teachers demand the best COVID protections in schools. We are in the midst of developing COVID weather reports on the state of the pandemic based on epidemiological data rather than what corporate America demands. We demand a layered, collective, and equitable approach to the pandemic. We recognize that none are safe from contagious disease until we're all safe. It is with this understanding that we will continue to share the latest on the state of the pandemic, toolkits for actions, and recommendations on what to do, developed for and together with community organizations. For it is only through collective power that we can create a new, more equitable world that can not only control outbreaks, but also prevent them from emerging in the first place. We hope you will join us. You can see there on the screen the names of various people affiliated with this organization. Their website is peoplescdc.org. So I went to their website. I liked that statement a lot, so I did check it out. And I found a statement here. This is from March 4. And this is about that, the unveiling of the new COVID map, the community risk rather than the community transmission map. That, the community transmission map looks like shit. So they're like, here, let's make the whole thing green by just not caring anymore. So here's the People's CDC statement on the US CDC's change to COVID-19 guidelines. On February 25th, 2022, the CDC released updated COVID-19 guidelines that are heavily focused on individual actions as opposed to community-level policies. The CDC's new guidelines are at odds with the fundamental tenets of equitable public health practice. The updated recommendations don't align with the best science if the goal is to prevent infection and suffering from illness, including long COVID, and potentially death, and from all the associated costs of coping with COVID. The CDC is telling us that we as individuals can afford to bear those costs, and it's telling us that the institutions that should be helping us, our government, our workplaces, and others, can't afford to help us. The people who can least afford to pay will pay the highest cost. The new guidelines ignore the well-being of those most vulnerable communities who have been most affected by COVID, including the immunocompromised and disabled, the pregnant, those with lower incomes, those working in higher-risk jobs, Indigenous, Black, Latinx communities, the unvaccinated, including children, the elderly, diabetics, and others with chronic diseases. The new guidance further shifts the burden of responsibility onto vulnerable people to fend for themselves and to make difficult, constantly changing risk assessments. These recommendations do the political work of trying to convince the public that this pandemic is over. They suggest we accept that there was no way for us to avoid the nearly 1 million dead in the US so far. Comment. You basically hear that in Fauci's earlier interview. They suggest that there is nothing more that we can do than to let this virus spread. They suggest that those without chronic illness and disability can live a, quote, normal life with COVID still in the air, while those with health concerns need to be pushed aside. We reject ineffectual public health policies based on individualistic approaches to pandemic management. The People's CDC advocates for a layered, collective, and equitable pandemic approach at all levels that would prevent infection spread and protect the most vulnerable among us. So, I don't know about you, but I would really prefer to have that CDC. I recommend checking them out. Again, it's Peoples, Peoples, CDC.org. So, I'll tell you what, we've been going for about an hour and 15 minutes. I know I said I was probably going to do 2 segments. I think I'm instead going to save the rest of the content I was going to put in this part for a part 1.5. So we'll do 3 segments because I think that that's actually a good note to close on. We'll be back with the next segment in this COVID update. And again, I've got like almost 24 articles altogether to get through. It's been kind of a crazy couple of months in this way. I mean, the whole post-Omicron looking at, the pandemic situation is like, I mean, Omicron really rocked our world. Like that was suddenly the pandemic got way, way, way worse. Then, inevitably the surge came down, but it's like, holy shit, what was that? And is it going to happen again? And of course, the government seemed to be like, oh, no, everything's fine now. Don't believe that. Don't believe that for a minute. Check out the People's CDC, get involved with whatever you can. And we'll be back in another day or 2 or 3 with the next segment. Until then, thanks for listening. Leave a question or comment in the comments area below. We'll continue the discussion there as always. And thanks to the current patrons whose names are on the screen. If you'd like to get your name on the screen, we don't run any ads on this channel, so that support is really appreciated. Go to patreon.com/socialismforall. You can sign up for as little as $2 or more, whatever you see fit. Those contributions have allowed me to spend a lot more time creating content and doing the research and doing the video editing and uploading and promotion and all the stuff that needs to happen to keep the channel going than I would have been able to do without that support. So it's very much appreciated. I thank you all for that. Beyond that, once the content has been created and uploaded, engagement helps to boost it in the YouTube algorithm. So liking, sharing, subscribing, commenting, all that stuff, it helps the channel to grow, to be boosted. It helps other people to stumble across this content more easily, and that's what it's all about. We're trying to make this accessible. It is socialism for all, after all. Your engagement has been helpful in building this channel into what it is, and future viewers who haven't stumbled across it yet, thank you for that engagement. I'm going to leave it there. Thanks again, and we will catch you in the next video. Stay safe.